Welcome to Medicap's PDS Express. In today's masterclass, we'll be learning furcation. Now, furcation, this topic, it is generally for your long note. Now, when I say long note, you need to write the entire topic right from the definition, classification, etiology, clinical feature, prognosis, and the treatment part. So, treatment part of furcation will be dealing in the next part. So, eventually, we'll be reading this topic in two parts. In first part, I'll be telling you the classification, clinical feature, prognosis, and the etiological factor for furcation. And in next class, we'll be seeing solely the treatment for this furcation. Now, long note can be asked completely on the full topic, but short note specifically can be asked on the treatment of furcation or the classification of furcation, grading of furcation, and etiological factors. So anything can be asked. So you need to be thorough with this topic. Now, this topic, this is also important from your clinical point of view as well, because you'll be taking so many case histories, and also for your vivas. A lot many questions can be asked on furcation, right from the definition of furcation, the grading of furcation, etiological factor, prognosis, clinical features, and everything. So let's start with the topic. So basically, furcation, it refers to a condition in which bifurcation and trifurcation of a multi-rooted teeth, they are invaded by the disease process. Now, what do you mean by furcation? So furcation is a point from where the root is dividing or splitting, you can say, into two. Okay, so this is the furcation area, right? So ideally, it has to be covered with gingiva till here. But what will happen? What is happening here? Gingiva is recessing down, and because of which the furcation area, it is clinically seen, right? Now, coming on to etiology. So there are multiple etiological factors which are responsible for this furcation involvement. Let's see all these etiological factors. So it is a bacterial plaque with long-standing inflammation of the periodontal tissue. The extent of attachment loss, it is related to anatomic consideration. Now, what all are the anatomic consideration of the tooth which are responsible for this furcation involvement? So first and foremost is the root trunk length. Okay, so let's say, suppose if this is the tooth, right? So they are saying the root trunk length. Okay, so portion of the root between the cemento-enamel junction and the separation of the root is the root trunk length. Okay, so this is the root trunk length. Now, root separation, portion of the root where adjacent roots forming the furcation are not in contact. Then third is the surface of the tooth just coronal to the root separation and the root of furcation. All these, they are the anatomical reasons because of which the furcation involvement will eventually take place. Now, coming on to next factor, that is tooth. So as I already told, the root trunk length, right? When the root is short, furcation will become more involved early in the disease. Okay, so again, I'm drawing that same thing. Let's say, suppose this is the tooth, and this part is short. Let's say, suppose it is starting from here. So early recession of the gingiva eventually will also lead to this furcation involvement. So they are saying the same thing. When the root trunk is short, the furcation is involved in the early phases only. Then concavity on the inner surface of the exposed roots. Now this may make instrumentation for the plaque removal and root planning almost impossible, because of which recession will take place. Then degree of separation of roots, or you can say the interradicular dimension. So wide separation of the roots, they improve the axis. Then cervical enamel projection, they favor the plaque accumulation. So here you might have seen a structure like this. So this is known as cervical enamel projection, which is eventually responsible for this furcation involvement. Then anatomy of the furcation. So presence of any any accessory canals can complicate the furcation treatment. So this is again an important factor. Then presence of accessory pulpal canal can also lead to furcation involvement. Then coming on to next factor, that is bone. So bone shape in the exposed furcation area has a horizontal component that determines the grading of this furcation involvement. Okay, so it could be like grade 1, grade 2, grade 3. I'll be telling you in the next slides only that what is grade 1, grade 2 and grade 3. So eventually if it is around 3 millimeters, then it is said to be grade 1. Okay, so we'll be seeing that. Now the vertical component can also appear as a vertical or angular loss towards the one of the root surface. Then coming on to next factor, that is gingiva. So sufficient attached keratinized gingival tissue and adequate vestibular depth will facilitate the gingival management. So again, this is an important factor for furcation involvement. Then coming on to next thing, that is classification. So there are numerous classification for this furcation involvement. Let's see all these things. So grade 1, basically it is divided into 4 grades. So in grade 1, what you can see, so it is the incipient or the early lesion. Pocket is suprabony. There is slight bone loss, right? And no radiographic changes are there. So this is grade 1 of furcation involvement. Coming on to grade 2. So bone is destroyed and on one or more aspect of the furcation and partial penetration of the probe into furcation, but it is not through and through. You can just penetrate your probe into the furcation area slightly. That is grade 2. So this is radiographically evident. Then coming on to grade 3. So interradicular bone is completely lost in grade 3 of furcation involvement. Furcation opening cannot be clinically seen. Now lesion will appear as a radiolucent area between the roots. So they are talking about radiographic appearance of grade 3. Then coming on to grade 4. Gingival tissue recede apically so that the furcation opening is seen clinically and it is through and through. Okay, right from you can say the buccal side, you can just pass your probe to the lingual side. So radiographic changes are essentially the same as of grade 3 lesion. That means you can see a radiolucent, that means black area between the roots, right? So you might have seen the radiographs where here you can see the radiolucency, right? So this is furcation involvement. Here also bone loss will be there. So they're talking about this. Then coming on to vertical component. So based upon the vertical component, there are 3 divisions. Subgroup A, vertical destruction bone up to 1/3 of the interradicular height. Then vertical destruction of bone up to 2/3 of the interradicular height. And group C is vertical destruction beyond the apical third. Then coming on to horizontal component. So as I already mentioned, horizontal bone loss of less than 3 millimeter, it is known as degree 1. Horizontal bone loss of more than 3 millimeters is known as degree 2, and degree 3 is through and through horizontal lesion. And this is neighbor's probe with which you tend to measure the furcation involvement. So furcation can be clinically detected by using neighbor's probe, and this is your neighbor's probe. Now coming on to other classification. So Goldman also has given one classification in the year 1958. So this is an additional information. If you'll write an exam, you'll get good marks. So grade 1 is incipient. That means the initial amount of furcation area involvement is there, and that is not much clinically evident. Grade 2 is cul-de-sac. Cul-de-sac means a blind sac, you can say. It is not blind, right? So you cannot see through and through. You can just insert your probe, but there is no through and through connection in this grade 2. Grade 3 is through and through. Okay, your probe will be passing through and through the lesion. Then according to Remford and Ash in the year 1979, it again has been divided into 3 classifications. Class 1 says tissue destruction less than 2 millimeter. In horizontal, they were saying 3 millimeters, right? So you should not confuse with that. Then class 2, that means cul-de-sac, tissue destruction more than 2 millimeter, and class 3 will be through and through involvement. So this is the classification for furcation area. Now let's see the clinical features. So clinically in the advanced stages like in grade 3, grade 4, it is much clinically evident and you can clearly see the furcation area. So mandibular first molar, they are the most common sites, and maxillary premolars, they are the least common site. Again, these type of things, they are important for your viva. Now denuded furcation can be visible clinically, associated with suprabony and infrabony pockets, Periodontal abscess and root caries and tooth mobility, they are common, but tooth mobility, they are seen in advanced cases in 3 Furcation area and 4 grades. Okay, in all these things you can see, you can feel this mobility. Right, now coming on to prognosis. So maxillary first premolars, they are placed buccally and palatally with furcation opening into mesodistal direction. Therefore, they have poor prognosis. Again, I'll say it's important viva question. Examiner can ask you the prognosis for this furcation, and they'll ask with which tooth it is like poor prognosis. So you will say that maxillary first premolar, and the reason I've told. Now maxillary molars furcation may open buccally, mesally and distally. Because of the presence of 3 roots, access is difficult and hence again poor prognosis. So eventually furcation involvement in the maxillary teeth, they show poor prognosis. Mandibular molars, they have 2 roots placed mesally and distally, and the furcation opens horizontally, buccolingually. So eventually the prognosis of the furcation involvement in mandibular first molar, it is considered to be good.